Greetings and welcome to Best of the Day. My name is Brad Monk. I'm a gynecologic oncologist from Phoenix, Arizona, the University of Arizona Cancer Center, Phoenix. And after 43 years, the GOG has come to a halt. But the good news is we are now part of Energy Oncology. We are here to discuss some issues related to ovarian cancer and angiogenesis specifically. I'm here with my good friend, Michael Beer. Greetings.
Hi, Brad. Thank you for inviting me.
It's great. Professor Beer is from Harvard Medical School, Massachusetts General in Boston. We try not to hold that against you, but welcome. Let's begin by talking a little bit about some of the scientific rationale to study angiogenesis in ovarian cancer.
Well, as you know, Brad, this data worked out probably 20, 30 years ago, where people began to appreciate that for tumors to grow, they require a blood supply. And the blood vessels within the tumor are structurally somewhat different than blood vessels in the rest of the body. And so it dawned on scientists in the field over a period of time that these might be a reasonable targets for anti-tumor treatments. And so there was a very large effort over 2 decades to characterize all the components of those blood vessels, to begin to characterize the proteins involved, and to make therapeutic agents. That then morphed into both in vitro, meaning in the lab, and then in vivo in animal studies. And those first initial studies were quite exciting. To remember that the blood vessels, as opposed to the tumor, are not genomically unstable, so they're really great targets.
Right.
And that's now morphed into just 10 to 15 years of very large validation studies and phase 3 studies in patients.
But don't you get the sense that ovarian cancer is different? I mean, I remember in the development process that anti-VEGF therapy was only supposed to work when you added it to chemotherapy, like in colorectal cancer and lung cancer. But there's a unique single-agent activity in ovarian cancer.
Right, absolutely. And so to show you how little we know, and particularly me, when it was first proposed, and you were sort of involved in this work, that this would be a reasonable target in ovarian cancer, I immediately said that would be probably the least likely tumor to be involved, because we find patients where it's floating in this fluid called ascites, which looks like tissue culture fluid that we use in the lab, and I would think that these cells would not be dependent on blood vessels. Nothing could be furthest from the truth. There is no doubt that we now know there's a very strong signal that this tumor is exquisitely sensitive to anti-angiogenic agents. So if you look at the phase 2 trials that were conducted, 170D, which was GOG, there was a Harvard study by Steve Canestra. They were going simultaneously. And you look at both response rate and percent at 6 months for PFS, the only agent that stands out from the phase 2Q is bevacizumab.
So
very striking.
Which basically what you said was this may be as good as chemotherapy.
Well,
and we've never compared it head to head, but I think it would be an interesting thought.
Yeah, and certainly less toxic.
Certainly less toxic.
Yeah,
no question. In fact, the bowel perforation issue has probably been over-exaggerated when bevacizumab is used early and in patients that have no obstructive symptoms. So maybe you could review with us the 2 landmark New England Journal papers where bevacizumab was added to frontline therapy. Tell us about the toxicities and the benefits we're seeing in those 2 frontline trials.
Right. So those studies evolved very rapidly from the phase 2 trials. You were heavily involved with it, Bob, and then over in Europe. GOG 218 was the United States trial. ICON 7 was the European trial. Roughly similar designs. GOG was a randomized phase 3 trial with 3 arms, standard care using chemotherapy, chemo plus concurrent bevacizumab, and the third arm was concurrent bev with the maintenance phase. It was placebo-controlled, very well designed. ICON 7 was almost the same, except there was only 2 arms, slightly lower dose, and some differences in the maintenance duration. And this, I think, is a take-home message from all the trials we'll talk about today, which is that there is a remarkable consistent result from all the studies in terms of the effects of bevacizumab. So if you look at GOG 218, there was a prolongation of PFS of about 4.2 months hazard ratio in 0.7 range, highly statistically significant. Icon 7 was a little bit lower, around 2.5, 2.9 months. But again, strongly statistically significant with a hazard ratio of about 0.7. Toxicities, very consistent across both studies and what you would predict.
Yeah.
Hypertension, primarily. The bowel perforation rate that was seen primarily in the Harvard study, which was quite high, and those patients had a lot of bowel obstructions, et cetera, was very low and very tolerable.
So that was exciting, and that was a game changer. And in fact, those studies, particularly GOG 218, has led to registration around the world, not in this country.
Right.
Although the single agent activity that you spoke about earlier is an NCCN Guideline 2A recommendation. But rapidly, as you already used this word, it went into platinum-resistant and platinum-sensitive patients. So tell us about those trials.
And again, the take-home message is a consistent results even in those studies. So it rapidly evolved into platinum-sensitive recurrence in the Ocean trial, in which Bev was added to the carboplatin gemcitabine backbone. Again, a prolongation of PFS of about 5.5 months. Hazard ratio even a little bit better, 0.58 in that range, highly statistically significant. Hypertension was absolutely in the same range, some proteinuria that most of the time the patient doesn't even know. So confirmed in a recurrent platinum-sensitive setting what we already knew up front. And then the Aurelius study, in which
platinum-resistant,
platinum-resistant, in which bevacizumab was added to sort of dealer's choice. This is primarily a European study. So that would have been Doxil, topotecan, or weekly Taxol, showed a remarkable increase in patient in tumor response rate, and a prolongation of PFS from about 3.6 months to about 5.7 months, highly statistically significant, hazard ratio about in the same range, maybe a little bit better. I think Aurelia is particularly interesting, as you know, because if you tease out the subgroups,
right?
I think Doxil and topotecan would be as we would expect, but the weekly Taxol arm is really quite staggering.
Sure.
With PFSs out around 11 months.
Yeah.
And that actually translates into an overall survival difference, which is statistically significant. Of course, we know that's a subgroup analysis, so
right.
we worry about that a little bit. But I can, you probably know this, certainly in my institution, it's converted a lot of sequential people who would give Bev, after or before weekly Taxol in series, to using it concurrently.
I think so.
Yeah, and I think it pretty much has come to standard.
So I hear people that say, look, Brad, you got to use Bev up front. That's where you get the longest, most duration to maintain the longest tumor control. But you also use the biggest duration, so maybe it's too expensive. Maybe there are patients that don't need it. Maybe there are patients that are cured. So then I say to people that let's reserve it for second line. That's where our bang for the, no pun intended, the buck is. How do you figure this out? Right. And maybe it doesn't matter. I don't know if we have I don't think we have a randomized trial of frontline versus recurrence. How does a clinician, the audience, figure out whether or not to use Bev frontline or at the time of recurrence?
Yeah, it's a really good question. And I think if the regulatory authorities had just looked really carefully at the data and given us a break, we wouldn't be debating this because it would be approved up front. In some ways, it comes down to practicalities, depending upon where you are in this country, whether it's approved by insurance, et cetera, et cetera. But I'm actually looking from a scientific standpoint, looking really carefully at 218 and Icon 7. I really believe that this should be approved up front, and I would use it. But not having that option
because of reimbursement issues.
Correct. And the reason I argue that is because I do think there isn't a single ovarian cancer patient who, prior to getting really seriously ill, in my opinion, should not see Bev. They all should receive Bev. The only question is when.
That's my point.
Yeah,
that's why I'm asking.
And I wish I had the option that they could get treated up front. In Massachusetts, it's difficult. And the reason I argue that is because it's partly because you do have that group of patients who don't respond well to chemotherapy, and they get sick very fast.
Right.
and they may be a group that wouldn't even have the time to get the advantage of bevacizumab. So that worries me. But since that's not an option, and occasionally, we're using it almost completely in recurrence.
Interesting.
And the only patients who you'd be concerned about would be the patients who ended up on the Harvard trial, frankly, that they had multiple bowel obstructions, they've had multiple surgeries, and you think a little bit twice about that. Although I will say, we have treated patients who have been very, very sick, and I have yet to see a perforation, actually.
So you didn't mention it, but you implied that the weekly paclitaxel Bev could also control ascites?
Absolutely.
So there is a role for symptomatic relief, and maybe those patients are very sick, and that's why you're using it.
That's right.
Interesting.
Absolutely. So sometimes you have a bit of a conundrum in those patients who have a lot of ascites and may have a partial bowel obstruction, who are sick, may also benefit the most from it, and you sometimes just take a chance on that.
So let's talk about another study which maybe informs this. It's complicated, but it's a study called GOG 262, which has been presented in Europe, and so many of our listeners may not be familiar with it. This was an attempt to confirm the Japanese observation that dose-dense weekly paclitaxel at 80, every week, no breaks, with Q3-week carboplatin, can improve outcome, improve survival, at least in Japan. So we want to do the same thing within the legacy GOG group. The difficulty was, as we said, this was in a time when we really liked Bev and we thought it was going to be approved by the FDA, and so we're trying to move forward. So we said, okay, investigator, you pick to see if you can use bevacizumab. And to be clear, in the absence of a reimbursement issue, 85% of our group chose it. So you're not the only person that wants to use it up front. So we did that, and in the unselected patient population, there was no difference in weekly versus 3-week, but most of them got Bev. So then someone said it was a stratification factor, so the patients that didn't get Bev and got either weekly or Q3 week, prognostically they looked the same. Let's look at that subset. And in the patients that didn't get Bev, the weekly was better than the Q3 week, just like Japan.
Right.
And in fact, the weekly without Bev had the same PFS as Q3 week with Bev. How do you integrate that result now? It wasn't pre-specified, but sort of, because it was a stratification factor. Right. Does that say, well, I don't need to use Bev up front because I can do weekly?
Well, it's interesting. I think, first of all, we're all a bit reassured on the patients who didn't get Bev that we at least, it looks like we reproduced the Japanese result. Although it's a subset analysis, it's small, but it suggests there's something interesting about those stents. I think that the result is actually quite interesting. I think it suggests that bevacizumab, the impact of bevacizumab, in some ways is very similar to dose dense. And whether that's based upon the mechanism of action, because as you know, dose dense has been argued to be an anti-angiogenic agent. I'm not sure if it were similar to or identical to, then it would suggest that you wouldn't get the synergistic activity in Aurelia. One way to explain that may be that there's a fundamental difference between ovarian cancer initial diagnosis and ovarian cancer when it becomes platinum resistant, that there's been a switch in the angiogenic factors so that in the platinum resistant group of patients, you do get synergism. What's interesting is there have been a couple of practical outcomes from this, at least in my practice. I've had a number of ladies who could not take dose dense because they had too much myelosuppression. Right. I switched them to Q3 weeks and added Bev. And I used 262 as evidence for that. Interesting. Yeah.
So here's what Berger and I talked about in the last interview. So we are studying a PARP inhibitor maintenance in BRCA germline mutation cares. It's called, as you know, GOG 3004 or SOLO-1. So Berger and I were talking, maybe we should start the patient on weekly, okay, because we don't know. And if you get Bev, you can't go on the PARP maintenance trial. So during that time, test her for BRCA 1 and 2 because it takes time. And if you're BRCA positive, continue the weekly and go on the PARP trial. But if you're not BRCA positive, as you said, convert to Q3 week with Bev. So to say it another way, if you're BRCA negative, get Q3 week and PARP at platinum sensitive recurrence. But if you're BRCA positive, get weekly without Bev PARP in frontline maintenance, and then Bev at recurrence. Is that crazy, or what do you think of that?
Well, no, I think that's actually quite interesting. I mean, it's beginning to take a patient population, high-grade serous tumors in particular, where we think they're completely homogeneous, and beginning to separate them out with targeted therapies is sort of a precision medicine approach. I think that's interesting. The only caveat I would say is, there's some accumulating evidence, not with Bev, but another anti-angiogenic agent, that there may be an interesting synergism between anti-angiogenesis agents and PARP inhibitors.
So let's move on, because we talked about that at this meeting. Tell us about the synergy between anti-angiogenesis drugs and PARP inhibition.
Yeah, so there was a lot of, well, I would say not a huge amount, but there was a fairly substantial amount of preclinical testing that goes back a number of years ago that suggested that PARP inhibitors themselves had an anti-angiogenic effects. Mechanism kind of unknown, but it was demonstrated. And so the supposition was that perhaps adding the two would either give you additive or synergistic effects. The results that have sort of evolved recently is the addition of a TKI that has some anti-angiogenic effects to PARP inhibitors is showing some remarkable responses in PFS prolongations. And that's in a platinum-sensitive recurrence patient population.
So again, presented this fall was ICON 6, chemotherapy, placebo, chemotherapy, cediranib, a tyrosine kinase inhibitor, anti-VEGF, and there was actually a survival advantage, although it was kind of a strange study that was stopped early, but provocative. And the beauty of it is you and others, cediranib and olaparib are made by the same company. So you can get away with this intellectual property sort of combination. I'm excited about that combination.
Very much so. And I think getting back to the cediranib trial from Jonathan Letterman, I think there's some lessons to learn on that. Most of the trials we've been talking about have shown a PFS prolongation without an OS effect. And we can talk about a lot of crossover and other problems. But that trial showed not only a PFS prolongation, but an OS change, albeit the p-value is pretty small, but that's pretty exciting.
It is exciting. And probably going to be the resurrection of that drug. We'll see, that drug was negative in lung cancer, and maybe we'll see what's going to move forward.
Yeah, there's no doubt, at least short term, that AstraZeneca is going to go with it. Yeah.
So we got 4 positive trials with bevacizumab. We got
6,000 patients.
Yeah, right. And we still don't have a label. 4 positive trials and 6,000 patients. You just want to poke me in the eye. I get it. And then we got a TKI with a survival advantage, and there's no talk of submission to the FDA. Thank you very much. That makes me feel better. Let's talk about other targets. I've thought about angiopoietin 1 and 2. Tell us about that.
Well, and again, before we go there, you should throw in the pazopanib trial too.
Oh, right. Let's talk about it. So before we get to thank you, to angiopoietin 1 and 2, tell us about pazopanib maintenance, anti-VEGF maintenance. Thank you.
So again, another TKI shown in maintenance, remarkably similar result with prolongation of PFS in the German trial.
5.6 months.
Correct.
So thank you.
So it's always reproducible. You've got to believe that this is a tumor that responds to that kind of therapy.
Completeness.
And it's an oral drug, reasonably well tolerated. I do think there's a little more toxicity for that drug than something like that.
And if you want to get technical, there's an inditinib, a third TKI. So we got 4 bevacizumab and 3 different TKIs that all have positive. All right, now let's talk about angiopoietin.
Yeah, so again, one explanation for PFS prolongations and not OS is that some patients benefit and others don't. And so there's been a big search for biomarkers to try to identify that. I've been doing some of that work, and it's been very difficult. And that may reflect the fact that there's more than one target. There's more than one mechanism to grow tumor blood vessels. And that gets to other targets then. So we move beyond VEGF. And I think ANG1 and ANG2 are quite interesting. So there's the poster trial for this, of course, is AMG 386. Been around for a while. A lot of preclinical testing into now 3 major trials. There are some other smaller companies that have agents that target those proteins. These proteins are fundamentally different than VEGF. VEGF really tells the blood vessel to grow. These are more involved with telling the cells in the blood vessels to survive, and they stabilize things. So you could argue that inhibiting, that maybe one of them is a resistance molecule for the other.
That's what you
maybe adding, targeting both of them simultaneously would be important. So I think that's an exciting approach. So the trial you're referring to, again, which is your trial, I believe.
Trinova 1. You talked about weekly paclitaxel and Bev. This is weekly paclitaxel and AMG 386, which is now known as trebantinib, hazard ratio 0.66. So it's a different target. It's not the greatest any more than these other things are the greatest, but it's a step forward. And
surprisingly similar.
Surprisingly similar.
Ratio. It's remarkable.
But what you said is probably a marker of VEGF resistance is angiopoietin 2.
Possibly. Yep.
We should target them both.
Absolutely.
Yeah.
Yes. So, I mean, I think those, so where we go with that agent, I think is going to depend upon Trinova 3.
Right, which is a frontline trial.
That's right. But maybe where we're going to be, 3-4 years from now is combining those agents.
That's right.
Or using them sequentially because one contributes to resistance.
That's right.
Yeah.
So we talked about 4 Bev trials, 3 TKI trials, all VEGF, 7 of them. The 8th positive anti-angiogenesis trial, angiopoietin 1 and 2. What are the next targets? Angiogenesis.
Yeah, so we're not finished. This is a complex process. There is a delta-like ligand 2 target which interacts with the Notch pathway.
Right.
And Notch is very important, not just in blood vessel formation, but there's some data that maybe is involved in stem cells. So it's very exciting. That's an antibody that's produced from a company. It has already shown some responses in phase 1, phase 2. It's interesting, it has a completely different profile of toxicities. There's minimal hypertension, but there's pulmonary hypertension.
Interesting.
So that, no one wants to see toxicity, but the fact that the profile is different really tells you you're hitting a different target. So, I would think what you're going to see in a couple of years as this sorts out is we may have a better idea of when to use agents like Bev.
Right.
Bev will be certainly here for a long time. But more importantly, we'll get an idea of how we use these things sequentially.
Right.
We don't even know whether Bev after Bev works, right?
We're studying
that. We're studying that. And then do we switch from one agent to the other, and do we use them in combination?
Right. Listen, this has been great. I really appreciate you taking time away from your busy schedule. It's been my pleasure to be with my good friend Michael Beer from Massachusetts General Harvard Medical School. This has been Best of the Day at the first Energy Oncology meeting from San Diego, California. Thank you, and so long for now.